edition of DX Summit being organized by CII and Center for Digital Transformation. Today, we have a session on building unique and innovative strategies for healthcare and life science sector opportunities and ROI. Before we begin the session, I request all the speakers to keep their mic on mute and unmute while speaking. I also request the speaker to keep their videos on while speaking. The session will be chaired by Dr. Pankaj Gupta, founding member, Libra Social Research Foundation. The other esteemed speakers of the session are Dr. Sujoy Kar, Chief Medical Information Officer, NVP Apollo Hospital; Dr. Barnali Das, Consultant Biochemistry and Immunology Division, Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute; Mr. Kumar KV, Vice President, Group CIO and CISO, Narayana Hospital Health; Mr. UK Ananta Padmanabham, Member Advisory Board, MGM Healthcare, 10x Health Technologies. The program is being run on the CII High platform as well, where we have around 4,000 participants. I request participants to post their questions in a QA session in a Hive platform, and we will take them up at the end of the session. With this, I would like to briefly introduce Dr. Pankaj Gupta, our moderator for the session. Dr. Gupta is a visionary leader, dental surgeon, and a technocrat with masters in computer science, bioinformatics, and management from IIM Bangalore. Dr. Gupta is a NABH and ISO certified consultant. He has applied healthcare quality standard for healthcare process optimization. He has over 2 decades of healthcare industry experience, which enable process improvement, IT cost reduction, organization change management, and business transformation through implementation of healthcare IT solution for hospitals, life science, and pharma companies. With this, I would like to invite Dr. Gupta and request him to take the session forward. Over to you, Dr. Gupta.
Thank you, Sangeeta. It's a pleasure to be a moderator for such a, enlightened session, and all my co-panelists. I hope that, we will have a good discussion today. To set the stage, I think the topic itself is very exciting, but let me sort of, try to put some points on the table, and then, we can go for individual presentations. So digital transformation is happening in healthcare in a very big way. If you look at from a policy perspective, we have the National Digital Health Blueprint that has been published. The mission is in place. We are sort of pushing towards building the National Digital Health ecosystem. And not just that, on the medtech side and on the pharma research side, we've already done a whole lot. On the medtech side, all the medical devices are being listed under the Drugs and Cosmetics Act, and new policies are coming in place to support innovation on the medtech. I was part of a forum recently where we were evaluating different medtech device companies. And out of 50 companies that we evaluated, at least 30 of them had artificial intelligence and IoT built into it. So gone are the days when hardware used to be separate and software used to be separate. And similar sort of advances we have seen in vaccines, where mRNA technology and the latest technologies, earlier people used to do the wet lab and then go to the research and the clinical trials and all. But now this time the vaccine, because the pandemic didn't give us the time, what has happened is were developed using a lot of bioinformatics, a lot of digital transformations. So mRNA technology is all that. Protein folding has been, artificial intelligence has been instrumental in finding the protein foldings and things like that. So a whole lot of things are happening across the board. In terms of the adoption of the National Digital Health Blueprint and the creation of the ecosystem, if you look at it, the financial lever is likely to play a vital role. Financial lever is all the health insurances coming to maturity. Earlier, the number of population that was covered by health insurance was small. Now it is crossing the 50% mark. So, there is a major change that is coming in from a a system that was sort of being run as an ad hoc system to a more structured system where the payer and the provider will tango together. Also, the pandemic has exposed a system that was broken. We were sort of running from pillar to post to find beds, to find oxygen, to find drugs, to optimize the availability of the human resources. All that could have been done far better if we had the data, the transactional data of everybody. If we had the registries in place for the doctors, for the facilities, for medical equipment, if we had all the drug data available, then optimization of all this was possible across the board. So, we are at a turning point. I call it the inflection point, where all the standards are in place, the policy is in place, the money is on the table, the private sector is ready. I think the only thing left is to go and do it on the ground. So, with that, I will sort of request the co-panelists to make their presentations, and then we can get into a small discussion after the presentations. So can we start with Dr. Barnali Das to sort of have her short presentation? And if you can keep it short, we'll keep more time for discussions. But please go ahead, ma'am.
Sure. Thank you, Dr. Gupta, for kind introduction and the questions and starting this session. And thanks to CII for giving me this opportunity, and because I attended all the panels before, and it's quite interesting. So now I'll start my presentation. Can you share it? Or if you can give me the rights.
I guess that'll be Sangeeta.
You can see my slides, I think.
Yeah, it's perfect.
Perfect. So I will actually discuss some case study, because when my role here is, I am not like from IT field, but my role here is implementations, how to implement that in healthcare sector or hospital sector, the translational role, and what we understand, like being in lab or being in the hospital or as a clinical scenario, how we can implement or towards the digital world, AI, Internet of Things in healthcare of delivery. So how to do it? So let's hear from patients' testimonial. You can hear?
The
Yes.
sound is not audible. The video probably that you're showing, that sound is not audible.
Okay, so this is actually the patient daughter. She is telling, like, she came from Dalhousie. Her father was in Mumbai, and she rushed to, because he had 79 years old gentleman. He was doing his marathon runner and all, and suddenly he developed high fever, and daughter came from Dalhousie, and suddenly he became very sick, and he was admitted, and with the creatinine level, it was not a very high range or anything. So based on this AKIE alert, he was detected of acute kidney injury. And because of this electronic health record or AKIE alert, she is telling that her father was detected, and because of this electronic health record and E alert, so he didn't develop the chronic renal failure or CKD. So as we know, AKI or acute kidney injury is 5 to 10% of all hospitalized patients and carries significant and independent risk of mortality up to 20% in some studies. So electronic health record can modify patient outcomes, contribute to greater resource utilization, decrease healthcare cost and financial burden. So some papers suggested like mortality 0.8% reduction, length of stay reduction, and dialysis reduction 2.7% of cases. So what is in our cases, our scenario, what we have observed? If you see like how we defined AKI, so it's only 0.3 milligram per deciliter in 48 hours. So because of that, many a times AKI or acute kidney injury missed by even clinicians. And many of the patients who are admitted, like this is used for the screening purpose, many of the patients who are admitted, we don't do urine volume or urine output. So based on creatinine, just 48 hours, 0.3 milligram per deciliter raise, we give the AKIE alert. So because of that, and another is 1.5 time rise in 7 days. So based on that, this is our 15-day small study. So around 4,700 patients were taken, and we defined the algorithm, the rule-based. So why this is necessary, the digitization towards the digital world, why this is necessary? Because this relationship between the gap between the IT and gap between the information technology or AI or digitalization and gap between the clinician, gap between the diagnosticians are huge now. So we need to decrease the gap. So because of that, when they define the rule based on this, we have seen AKI alert was detected in around 4,700 patients, 273 patients, so around 6.15%. That's quite high for any hospital. So as we have seen worldwide, this is between 5 to 20%. So 6.15% AKI alert was raised. And so then we have gone through all the records, and 239 patients were true AKI alert, 5.38%, and false AKI alerts was 34 patients. So if we have seen, we have taken one subgroup, and if you see, we in 2,000 patients, number of AKI was 143. And when we checked 2,000 patient data, and when we checked all the data from our LIS and HIS, we have seen only 46 cases were reported. Toshrikar, his hospital set up all the best clinicians. Even then, only 46 cases were reported in 143 AKI alert when it was raised. So this is not, this is a global scenario, because many AKI cases where acute kidney injury cases were missed. And because of that, electronic health record or the role of electronic health record or all those machine learning or deep learning based or clinical decision support based rule applications and implementation in that in the clinical field is very important. So we have seen with that alert around excellent sensitivity, 99.53% sensitivity, specificity was 98.6, and diagnostic accuracy was 0.98. So in 4,439 patients. So, and 75.2% patients were critically ill with primary diagnosis of cardiac, pulmonary, nephrological events and comorbidities like hypertension, diabetes, and 40.2% patients had a documented clinical diagnosis of AKI. So if you see, for only 40% cases were documented as AKI. So with that, with AKI alert, around 60% patients, 60 to 68% cases were alerted because of this electronic health record or AKI alert. And overall in-hospital mortality rate was 21%. So this is one case where, this very simple case, creatinine, every day we are like, now we see so many patients doing creatinine, and it's not we have taken from nephrology unit or ICU. This is like general from OPD, IPD, all the sector. So this is just one screening parameters of small creatinine value can give so much implementation or impact in our healthcare delivery. So this is one. Second thing is high sensitive troponin I, because nowadays, because of COVID with cardiac injury, and we have had patient was doing in gym, sudden cardiac failure or sudden cardiac death, or some marathon runner, we have heard. And we have seen like NT-proBNP, our high sensitive troponin I cases raised. So this is the algorithm. So there is very much needed to bridge the gap, to sit with the accident and emergency or ICU or intensivist or the cardiologist, sitting with the lab, sitting with the information technology to define this clinical algorithm, or to define the algorithm so that we can prevent the heart failure, or we can prevent the acute myocardial injury. So this was our study, and we have seen with this implementation of clinical decision support by implementation of sex-specific reference interval, sex-specific cutoff of high-sensitive troponin I, 14% of the total cases in 6 months period were missed if we have not implemented that CDS based on the cutoff of male and female for high-sensitive troponin I. So this was our study in, and this awarded in Events of Healthcare, and it was reported in different news article and newspapers. So what CDS algorithm has done, protocol for rule in and rule out of heart attack, and just simple protocol helped to define around to diagnose 14% more cases in female. So like this was the story of heart attacks going undiagnosed in female, because atypical presentation of heart attack in females, so many times we missed. So when we defined the cutoff for her Indian female of high sensitive troponin I, so we realized that we saved around 14% of female patients with acute MI. And this was around 180 applications. This was the first 11 worldwide which have received this award. And so what is CDS? An expert knowledge system. CDS combines text and numeric data from available data sources like LIS, EMR, or HIS, and investigative results, and clinical activity, clinical data, and patient demographics. We cover all those things. Then then there is need or to bridge the gap. Clinicians, diagnosticians, and IT, and everyone, like machine learning and deep learning, we don't understand much which rule to implement, but we understand like what clinical context and what should be the algorithm. So because of that, this empathy towards patients, this patient care is very much important. So develop rules by expert, subject matter experts, by algorithm defined, and what is the output of clinical excellence, like clinical result validation, test result interpretation, test suggestion, like in molecular biology, test suggestions, personalized wellness report, over and underutilization. Many times clinicians, like for autoimmune markers or neuroimmune markers, lot of tests, battery of tests, even in COVID, battery of tests was by WhatsApp people were ordering. So because of over and underutilization, so that is towards the digital health or digital world can help us. And risk stratification, like for this cardiac risk stratification was done by only the electronic health record, and evidence-based guidelines and gaps in care. So if we see, this is one, diabetes, what are the critical to quality, improved outcomes, lower cost, better patient experience, improved physician satisfaction. How? By only clinical workflow integration, scaling the existing care system, reduction of workflow steps, reduce the EMR clicks, and then clinical decision support, just to bridge the gap in the care exposure, closure during the discharge, helping patient, risk stratification analysis, focus on highest risk patient, measure quality improvements, and prepare for the value-based care and remote patient monitoring. During COVID, we realized because many of the cardiac patients, many of the patients were not coming to the hospital, but these are the chronic diseases. We can't ignore that. So for remote patient monitoring, this play a very important role. So the right information at the right time, very important for healthcare data, and patient outcome, critical clinical pearl, that is much more important. So this is one of our recent study with IIT Bombay, Koitia Center of Digital Health, the recent department. So for COVID-19, around 10,000 patients we have taken. And these are the simple biomarkers for all COVID patients. Even by WhatsApp, we are seeing every one of us who has done the COVID testing, like CRP and other tests like interleukin-6 and other CBC. So we have defined mild, moderate, severe cases. We have risk stratified between mild, moderate, severe cases. And then from IIT, they have developed the algorithm and based on deep learning based method. And they try to less amount of annotated data are available and data can be noisy. So they have implemented that algorithm. I'll not go into details because so based on that, we try to define mild, moderate, severe cases. Why? It's not important for our hospital setup, but if it outreach to remotest location based on one CRP result and CBC result, we can define mild, moderate, severe patients, and that has bigger impact. Similarly, the AKI alert, like if NHS has outreach program for AKI, so if this algorithm we can help like to outreach different location and multiple sites, so that really can help. And this is again another impactful for diagnosis of diabetes, early identification of diabetes, pre-diabetes. Pre-diabetes very common, but with HbA1c monitoring or glucose monitoring, if we can current treatment paradigm, if we can change. So this is one case study where they have with electronic health record, they have shown that assisting early use of GLP-1 and SGLT2 therapy as guidelines recommended, while most people start on metformin. So optimizing patient treatment and education and care team coordination. So this is like hypoglycemic alert, hyperglycemic alert, heart failure alert comes in patient clinician screen. So this is different other like health checkup, clinical validation, and coagulation and thrombosis by different markers like INR, D-dimer. So reducing intra-hospital complications, stratification between high risk and low risk patients, then intensive care unit. I said about COVID risk stratification and other critical patient risk stratification, early intervention, then diabetes care, sepsis care. By defining different treatment bundle, different algorithm, we can even chronic kidney failure or CKD patients, like simple eGFR implementation in LIS and HIS system can save so many patients. So patient safety, patient empathy, and patient happiness is the most important for any one of us who are working in our healthcare sector. So that I felt coming to epidemiology of COVID-19, so the different prediction models like machine learning based early models, Sutra models, SIR models, which can predict and project for first wave, Delta wave, and Omicron wave. So these are like SIR model. We know that the conventional early model susceptible, infected, and removed. And this is the Sutra model, the new model implemented during the second wave, susceptible, undetected, tested, positive, removed, and analysis. So this is the computation. So now towards, this is the summary slide of that, towards digital health. what we have understood from this epidemiology prediction with different prediction model, this Sutra model is versatile model that should be calibrated, and that can be calibrated using this caseload data, and the model can be used to predict caseload and health inventory going forward and quantify the impact of past policy decision, and it has been used successfully to predict the peak of Delta wave. And with the Omicron wave, we realize that our data which is available in our system is not sufficient. So analysis of South African data is excellent. And to understand the events and preliminary projections by assuming the South African changes, it can reflect in India, an updated prediction after Omicron arrived. So continuous refinement because of the parameter drift. So, but we realize that Omicron bypasses both natural immunity and vaccination. So Sutra can quantify the combined loss due to both factors. However, Sutra by itself cannot distinguish between the two. So actually, there are so many models, machine learning based models, but the complex nature of this pandemic as a result of biological and human forces has been understandably challenging due to relatively inaccurate number of confirmed cases, and these prediction models needed to be more dynamic and flexible as well as more real time. So this is AI implementation. All of us know like how AI have changed the whole scenario, how AI and IoT and all those digitization has helped us, like identification of disease cluster, monitoring, prediction of future outbreaks, mortality risk, diagnosis of COVID-19, disease management by resource allocation, facilitating the training, record maintenance, and patient recognition. So this is, all of us are healer. Maybe we are seeing the clinicians, this is my painting, maybe we are seeing the clinicians, but if you see this from IT, the perspective, if we see how they are extending their hand, because of your hand, the clinicians, the diagnosticians can help patients. So I acknowledge and thank everyone present here, because of all of us are healer, and you are the true healer who have extended your hand to help us.
Thank you, ma'am. This is a wonderful presentation. So, you talked a lot about evidence-based medicine, you talked about clinical decision support, and also about epidemiology. There was a time, when it used to take, 8 to 10 years of epidemiology research to bring any data to the clinician to be, converted into clinical protocols, and then, to be used further. So, but then, gone are those days, and now at least the pandemic is not giving us the time. So, and we obviously have to move faster, and digital comes, in sort of to sort of fill the gap, and is able to make data near real time, to do the analysis and provide insights into the data so that we can do clinical intervention. And this is something that the pandemic has taught us. And I think going forward, what had to happen in 10 years using artificial intelligence has already happened in the last 2 years. So there is an acceleration that has happened. So thank you so much, Dr. Banali. If you have any comments on the epidemiology analysis and anything related to the evidence-based medicine. So please feel free to sort of button into all the discussion that we are going to have. Thank you so much. We can go to Dr. Anant Padmanabhan. Sir, if we can sort of hear from you about hyper-automation of hospitals, as you call it, and no code or low code sort of setups. I call it microservices technology, which is the latest mobile first, cloud first because the world is moving towards that. If you look at Zomato, Ola, Uber, and Netflix, all of them are based on these technologies, which has a very small footprint. And we're moving into that era. Healthcare is lagging behind as usual. I mean, that has always happened. But I think the time has come to sort of take a quantum leap and go forward. And you are one of those stalwarts who's been sort of talking about it and doing it in your hospitals for a long time. So would like to hear from you, So please go ahead. So we can't hear you.
Are you able to hear me now?
Yes, sir. Please.
Yeah. Thank you, Dr. Gupta, for calling me because I thought my alphabetical Anantapatmanaman is A and Banali is B. I thought I will be called first, but as it happens in the colleges and schools, my alphabet is A. That was the advantage I had. So anyway, I think
lady,
start.
so ladies first. I wanted to have the lady go first.
Okay, good. Dr. Banali, I think your talk was excellent, and I think you brought science and chemistry and biochemistry, everything to IT. Thank you so much, and I want to thank CII for giving us this opportunity, and particularly I am very happy and proud and privileged to be a part of an eminent panel like this. I think that is very important, and this topic of digital transformation is very close to my heart. And I am very passionate about it. And being myself an engineer, maybe I've been working in the hospitals for a very long time. Believe me, I've been working for about 30 years as an operations manager, as an IT engineer, as a facilities engineer. And I think nobody can be more excited than this topic, believe me, on digital transformation. And I feel that digital transformation is a tool for social disruption and social maybe transformation. In fact, that is what is happening, as President Abdul Kalam said, that it can be a tool for social transformation. Okay, but when we are talking about this digital transformation, we are also talking about certain new technologies that has come in. I'm going to list out a lot of these technologies, but unfortunately, we don't have the time to discuss about all these 10 technologies. But I'm going to discuss about a few technologies which lead to hyperautomation. And one of those technologies is the low-code, no-code software platform. Can I have the presentation, please, or should I share it? Can I share it myself?
The presentation right has been given to you, sir.
Yeah. Are you able to see my screen? Are you able to see my screen?
Yes, sir.
Yes, sir, it is visible.
Yeah, give me 1 minute. Okay, this is the agenda I'm going to follow during my talk. And somebody was telling me that during one of our meetings, this IT is going to eat all the disciplines, whether it is engineering or medicine or transportation, or maybe even maybe something like entertainment. It will eat them for breakfast, lunch, and dinner, I believe. This IT will eat all of them. But no doubt, this has been a revolution in the last 5 years. And one thing that has happened is because of this COVID, the digital transformation has got accelerated. Okay. So I know in many occasions when I used to talk about digital transformation about 2 or 3 years ago in some of the forums, maybe many people said, oh, it may not fit India. It may not be suitable to India. It may be okay in America. It may be fine in Europe, but not in India. But today, I think everybody seems to be talking about AI. Everybody seems to be talking about telemedicine and things like that. But what I thought was we should go beyond AI. We should go beyond telemedicine and talk about something which is happening in the last 2-3 years. And that is where the hyper automation in hospital comes in. And we have this low code, no code platforms also coming in. So what is digital transformation? Quickly, digital transformation in healthcare particularly is about re-engineering, simplifying, digitizing the clinical and non-clinical process in the healthcare facility, fundamentally to change how we operate, deliver value and experience to the patient. I think it is about delivering value and experience to our patient. And it is also about a cultural change in the organization and top leadership commitment to continuously challenge status quo and experiment and develop innovative ways to deliver cost-effective and efficient healthcare. This is the definition. I don't want to dwell more on this, but I think it is very relevant to know about the inner meaning of this digital transformation. When we talk about digital transformation, it is just not about implementing a few IT solutions in the hospital. It is about changing the culture of the organization. It is about getting the total commitment of the top leadership. It is about revisiting some of the processes, some of the systems of the hospital. And it is not important, it's not right to automate some processes which are inefficient. I think you need to first re-engineer the process. We need to simplify the process and then only automate the process. So, and that is the very essence of digital transformation. So here, when you're talking about healthcare digital transformation, we are talking about 4 components in it. One is how do we digitize, how do we digitalize? I think there is a difference between digitation and digitalization. When you say, when I digitize, you just only maybe scan a document, or maybe you prepare an Excel sheet. That is only digitation. But if you want to call it as digitalization, it is about adding some intelligence to it, adding some workflow into it, adding some automation into it. And we are talking about digitalization. And I think in healthcare, unfortunately, the IT has not penetrated as much as it has in logistics, as in education, as in banking, as in entertainment. But thanks to COVID, I think an acceleration has happened. So the next one is the patient management and clinical care. That is what the previous speaker so eruditely brought out, but I'm not going to touch upon the patient management and clinical care, but I'll be more focusing on the healthcare facility. And third, also about the pharmaceutical research and development and population health. And I'm sure there are other people to talk about it, but I thought I will talk more about the healthcare facility. And then we must, before I get into the automation of healthcare facility, we must talk about hyper automation. What is hyper automation? Hyper automation or intelligent automation is the application. I think, I must do this. Okay, hyper automation, intelligent automation is the application of cutting edge technologies like low code, software platforms, Internet of Things, wireless technologies like BLE, LoRa, 5G, and for cloud technologies to automate all clinical and non-clinical processes in the healthcare facility to augment human effort and ensure operational excellence. What we must understand is, as somebody said, AI will not displace people. AI will not displace doctors or nurses, but people who don't use AI will be displaced. You understand? So that is how they put it. And so I think it is very, very important to understand that these hyper automation technologies have come in to complement the efforts of the humans, complement the efforts of the doctors, the clinicians, and also to ensure operational excellence and patient experience. Then these are some of the very nice technologies that have innovative and emerging technologies that have come into healthcare. We talk about IoT, Internet of Things, Internet of Medical Things, 3D technology, artificial intelligence, big data, genomics, edge computing, machine learning, low code, no code technology, cloud computing, pneumatics, quantum computing, wireless technologies like BLE, LoRa, mobile, biometric technology, robotic process automation, robotics, real-time location tracking system, and augmented realities. Honestly, it will be very difficult for me to talk about all this, which are also, no doubt all of them come together to make hyper automation, but I am only choosing 4 technologies here, namely the IoT, artificial intelligence, low code, no code platform, computing, and little bit of real-time location tracking to explain you what we have done. What I am going to talk about is about the concept of this hyper automation, and also talk about some of the practical implementation that have been done in Indian hospitals. So when you talk about hyper automation technologies, as I told you, I'm going to look at only these 4 technologies, namely the low code, no code application software platform, as we call it, the Internet of Things, the cloud computing, wireless technologies like BLE, LoRa, and 5G, and maybe little bit of Wi-Fi technologies, the evolved Wi-Fi technologies like Wi-Fi. Then real-time location tracking system, we call it RTLS. Then the artificial intelligence. These are all some of the hyper automation technologies which have come together in the hospitals. But what does this hyper automation do? And why do we need this hyper automation in hospitals? Because there is escalation of operational costs, high turnaround times, waiting times, no real-time data, 24/7 access to actionable information is not available for decision making, and loss of data and insights due to paper-driven culture in the hospitals. So what are some of the low-code, no-code applications? No-code, low-code applications are engineering and facilities management, asset tracking and monitoring, environmental monitoring, transportation management and monitoring, workflow management system, fire safety and fire prevention management systems, even business development. So this is a very important definition. I think we must understand it in the proper perspective. Low code is a software development approach with very little coding, and to build applications and process using without using the complex programming languages. 1 second. Let me push this up. Okay, using complex programming languages, and you can employ virtual interfaces with basic logic and drag and drop capabilities in a low code development platform. So what we do in this low code, no code development approach is we just don't do any hard coding. What all we have is some visual objects, and we just drag and drop and make an application. And the process owners, maybe a lab technician or an IT manager, or maybe an operation theater manager, or even a finance manager can become a citizen programmer. You just don't need to have any IT background at all. You don't have to know Python. You don't have to know Java. And now these process owners who are able to develop their own IT applications are known as citizen programmers. And it is said that 65% of the software applications are expected to be in low-code platforms by the year 2025, according to the renowned IT research organization called Gartner. I think this is a very, very interesting development that is happening. So, yeah, what are the 10 low-code platforms we have? These are all some of the, once again, please. Yeah, why low-code platforms? It requires very little coding effort and IT skills, but requires a lot of good domain knowledge. It is 10 times faster to develop software applications than the conventional programming. It is 75% cheaper to develop and maintain than the conventional coded software applications. Very little time is required for training and implementation. The concept of citizen programming is evolving. So you will find in another, say, 10 years time, the HR managers will start asking for low-code software skills to become an employee of the hospital. Like we are asking for, do you have a knowledge of Excel? Can you work on the internet? Those are all the skills which are asking now. But in course of time, all the professional managers maybe will be asked, do you have a low-code software skill to organize a department? And then the software technology is going to be the future, I am very sure. And these are all some of the low-code platforms. There are about 250 low-code, no-code platforms in the world, but these are all the top 10. You will see Genesis, Creoshow, Appian, Kissflow, Mendes, Microsoft, OutSystems, Salesforce. You know, I was thinking in the beginning that, okay, the big guys are not into it. SAP is into low-code. Microsoft is in low-code. Salesforce is in low-code. OutSystems is in low-code. Unless they see value into this low-code, they wouldn't have come into this low-code. So people like me have started working with Zoho Creator, and we have developed at least about 10 to 15 applications, as I've shown you before, and they are very inexpensive, very fast to implement. But the only thing is we need to get the buy-in of some of the users. And then we have also used the Internet of Things. The combination is about low-code platform and the Internet of Things coming together with the cloud technology. And these are all some of the IoT components, IoT devices, like maybe you have a IV-enabled drip monitor. You have these are all BLE tags. You will see some BLE tags and BLE badges, and you see these are all the GPS gateways which are put in the ambulances. This is the LoRa gateway for monitoring the temperature, humidity, water supply, and all that are put in the hospitals. And these are all the applications which we have developed. Believe me, these are all the applications. Now we are able to monitor HVAC, IoT-enabled HVAC system. I can monitor how many hours the HVAC system has run, and what is the efficiency of the HVAC system, what is the power that is consumed, Why did it consume more power? Same thing, I'm able to monitor the temperature and humidity of about 40 locations in the hospital, like operation theaters, ICUs, laboratories. Then we have about 40 refrigerators where we keep all these reagent kits, medicines and all that. Previously, if you see the nurse, even now in many hospitals, the nurses are monitoring manually in the data logger and entering it. But what we have put is, we have put these IoT devices in the refrigerators and then connected to our low-code platform, and we get all the data through this low-code platform and the IoT devices. Then you have GPS-enabled cardiac ambulances. We can also track the ambulances and then get the data into our low-code platform system. IoT-enabled performance monitoring ventilators. Ventilators, now a lot of ventilators are being manufactured, but we don't know how long they work. Maybe we are able to take a lot of these vitals, but honestly, I'm not into that business, but I'm into knowing the utilization of the ventilators, how many ventilators are used, how many hours it has been used, how much it has been charged. We are able to monitor the performance of the ventilator. Then we are also able to monitor the location of these ventilators, monitors, infusion pumps, syringe pumps, patients and all that using this. And this is the kind of dashboards we get out of the low code. You see, this is a very typical dashboard which we got about the low code platform. We built it in, believe me, in 2 weeks time we built this platform. We are able to monitor the operation theater temperatures, live temperature. We are able to see minimum, maximum temperatures, and we are able to see the refrigerators. Nursing stations have different temperature, and nursing stations have different refrigerators. We need to maintain between 2 degrees and 7 degrees. We have to maintain the temperature. We are able to see these are all live data. Similarly, we are able to monitor the ambulances. You know, the ambulance, we have about 10 ambulances. These ambulances, how many ambulances are there, how many trips they have made, how many emergency trips they have made, how many routine trips they have made, how many paid trips, how many outpatient, inpatient, what is the kilometer, what is the expense. We are able to do everything. Believe me, if you are going to give this software development to an IT guy, he will take about 6 months to 1 year and charge you maybe about 5 lakhs or 10 lakhs or whatever. But this can be very inexpensive and very fast can be done. This is the IoT enabled ventilator performance monitoring. You see here, these are all the IoT devices that are kept, and we can get the data like this. We are able to know which patient, which ventilator, which bed he was connected, how long he was connected, and this is connected to the HIS. Believe me, this data goes into the HIS. The HIS has a billing module. We are able to charge the patient and we are able to know the utilization. This is the location tracking system. We have BLE tags. We have the BLE tags here, IoT tags. It is put on the patient. It is put on Fitbit like a thing, and we are able to monitor when did the patient come out, when of the particular area, when did he come in, what is the total duration in which. This is a very interesting application coming out of this IoT. And this data fed into the low-code platform can be a formidable combination. So you are able to see, we can even track some of the patients who are moving in from master health checkup area from one area to another. They have to go to 10 different places, and we can track them, and so that we are able to know the turnaround time, waiting times. You are able to see that, and it is very useful. And last but not the least, I was telling you about, these are all the entire utilities. We can monitor HVAC, lighting control, signages, AHUs, energy management, water tech, and maybe you can do chiller monitoring, air compressor. All these can be done, and this is the kind of data you get. And because of paucity of time, I'm not able to tell you everything that we have done, but this is the kind of reports we get. But one good thing we are able to do is, because we have a common IoT platform, we have a common low-code platform. What we do is we partner with many of these IoT vendors. We also partner with some of the software vendors, and those data come into our platform, and then the CXO or the CEO has one login for the entire hospital. And from one login in this platform, in the low-code platform, he can see what is the consumption of water. He can see how many ventilators are working. He can see how many patients have come in. He can see maybe how many inpatients have come, how many outpatients have come, how many tests have been done. It may be in Dr. Pankaj's language, we create data lakes. We create data lake, and then we are able to really harness that information for greater insights. So this is what I wanted to give you a small brief about the digital transformation, the hyper automation, and low code, no code platforms that are being used in India, and I'm sure you will find them being very rapidly adopted in the future. Thank you, Dr. Pankaj.
Thank you, sir. A wonderful presentation. Although we are short on time and we have to move a little faster because the time allocated is sort of running out very soon. Before I move to the next speaker, I had one small question to you, sir.
Yeah.
That how do we make the HIS, HMIS vendors to move into this low code, no code microservices based, mobile first technology, mobile first and cloud first. So that is one question. The related second question is that, there is a lot of, resistance from hospital owners as well as, the CIOs to move into the cloud. Now, my point is that, gone are the days when you would have a client server based monolithic architecture, HMIS. We are moving towards a battery of mobile applications that will work together like an HMIS, and that can sit on a cloud, a elastic cloud, and be available not only in the hospital but outside in, various settings outside the hospital, because now hospital is not just hospital, it is going to the patient's home. So what do you have to say about that, sir?
Yeah. Both are very interesting and questions. I think somehow I missed out answering them even in my presentation. Nice that you reminded me, Dr. Pankaj. The first is about the HIS vendor being accepting this low-code platforms, right? What you must understand is that these HIS vendors, they find it extremely difficult even to manage the core applications like laboratories, like maybe operation theater, maybe EMR. They find it extremely difficult to manage the core applications. Whenever they go to different hospitals, they ask for customization. When the customizations can be very, can be time consuming, can be expensive, and they have to develop so many versions. This hospital has one version, that hospital has another version. Managing versions become difficult. So in fact, nowadays they are promoting low code, no code applications for those customizations, and they give APIs. They call APIs, and we can integrate our low code applications into their main application. And in fact, companies like Oracle, companies like SAP, companies like Microsoft have these microservices or the low-code application, and they also provide API. So you find that these vendors, HIS vendors, are now very nice in accepting these softwares. They welcome these softwares, and that is point number one. The point number one is talked about cloud. As I told you, I've been working in the healthcare sector for quite some time. I would have implemented about 8 or 9 HIS solutions in my career. And till the last 2, maybe if I say 7 solutions, I would have implemented 5 on-prem and the 2 on the cloud. It was on AWS or Azure or whatever. But believe me, I found after I started implementing on the cloud, I found my life very easy. So as I told you before, in the night, if I am handling about 8, 9 hospitals, like in Rainbow Hospitals Group, where I was the CEO, whenever in the night by about 12 o'clock, if the phone rings from the nurse in the Visakhapatnam hospital, my heart will start beating fast. Because she will say, no, my computer is not working, lab system is not working, I'm not able to enter the EMR. And so I need to call up my IT engineer. That fellow will say that IT engineer is at home. Then he will say it is not my problem, it is Microsoft problem, or he will say AWS problem. So, but today with this cloud computing coming in, so I know for certain it is not a server problem. I know for certain it is not a network problem. It is a problem of application or the user problem. So I think it becomes easy for me to manage this cloud. And last but not least, the cloud is also secure. Many people think that cloud hosting it is not secure. In fact, it is more secure than keeping your data in 10 hospitals in the servers. So it is like keeping your gold in a bank, in a state bank or an STFC, where it is more safer than keeping it in 10 different relatives' houses. Okay, thank you, Pankaj. I hope I have answered your question.
Thank you so much, sir. Moving to Dr. Sujay Kar, sir, it is actually very interesting to sort of come to you after all of these discussions that have already happened. And, there's a lot of, Internet of Things and IoT that is being implemented in the field. And artificial intelligence based devices are collecting humongous amount of data. Like, for example, these wearable devices, they say that we have billions of sleep data, billions of hours of sleep data. Okay, fine. But, what does it mean? Does it have a causation relationship? Does it have a clinical relevance? So, those are the kind of things that we would want to understand from you. So please go ahead, Dr. Sujay.
Thank you very much, Dr. Pankaj, and it was truly very insightful to hear both Dr. Barnali and Dr. Anant Padmanabhan on the work they have been doing. At Apollo Hospitals, you would understand that we now have EMR solution for more than 1.5 decades, and we are now working on longitudinal patient data. The longitudinal patient data, what we mean is this, that every interface that the patient would have had or encounters that the patient would have had during their entire clinical journey, we are able to capture them, whether it is an outpatient visit, whether it is an inpatient admission or a discharge. And then, of course, go into our other ecosystem like pharmacy, or now we have the Apollo 24/7 digital platform. One of the key ingredient in all of these is to capture all of these data together, put it in what you call as a data lake. And this has been done over for now almost 70 hospitals that we have in a system. So you can understand that the kind of data rich state that we are in terms of collecting this data over a period of time and then using this. So my job at Apollo Hospital starts where possibly the other jobs end. That is what to do with the data that is existing in the system. And therefore, what we have been doing in the past 3 years with the best of the industries available in each area and the academic institutions, we have been able to actually engineer on that data. When I mean engineering, I mean we are able to do a metadata management. We are able to transform this data appropriately without using synthetic data at any point of time. We are able to build in longitudinal models, which talks about either risk stratification, recommendation systems, developed natural language processing, guided conversational AI, which is there in our platform at 24/7. And we possibly have now about 24 of activities that we are, or programs that we are currently doing in different areas, including one of our flagship program, which is called Suitability, which predicts cardiovascular disease in next 10 years, looking at very simplistic, personal data, medication data, and all of that. But the work has gone to COVID, which we published in Nature last year. Then we have work coming out in liver fibrosis. We have work coming out in, pre-diabetes, which Dr. Barnali was talking about. And then, of course, another very interesting work where we have air quality index, right? So that actually talks about your high velocity data, air quality index with medication, patients vital, taking all of them together to predict if somebody is going to have an acute exacerbation of COPD over a period of time. But I think one of the most interesting problems that we have, and today I'm not in a solution mode, I'm in a problem speaking mode. And I think I'm a strong believer from my alma mater at MIT that questions are answers. And I'm going to put questions in minds of people to actually say, how do they look for solutions in certain areas where you have high velocity data coming in through either a Fitbit device or a device that is connected next to a monitor of a patient who is in a step-down unit or who is there in an ICU. And you would know, anybody who has been to an ICU, you would see all the kinds of beeps and things coming out from the entire ICU at that point of time. And many of the nurses would have to go and attend those alarms. So there are alarm fatigues. But what these alarms do is to provide you something what we call as an early warning sign. And this is the area that we have been looking at it, that how do this high velocity data, which has now been picked up every minute, or even less than a minute, and I'm talking about 6, 7 important vitals that come in, can have appropriate intervention for a particular disease condition, and not only for a particular disease condition, but also for that particular individual. where we already have a baseline data, and how do you go about in computing that data to understand, how what would actually come out of it. Just to give you an example, we did a study on a device for just about a month on about 100 patients, 127 or 30 patients, where we had in about a month, we had about 12 million data points coming out from only 4 or 5 different vitals. And from there, what we found out was that the alert was only coming up in about 110 situations, whereas the doctor needed to intervene only on 8 situations, and only on one particular situation that the patient needed to be shifted to ICU. Now, you can understand that that bit of information is now getting processed in the minds of nurses or junior doctors who are attending in our critical care. How do we go about using computation on the top of it, use edge devices, use cloud computing to ensure, we build models which will pick up these important clues out of this high velocity data and point out where it is absolutely relevant. This is a very, very interesting engineering question, so as it is as a clinical question. The other thing is that after doing about, say, close to 20 models and working with the best of the minds in academia and computer science and institutions all over, one of the questions that the doctors are asking us now is that we know about the risk scores, we know about the early warning signs, and there are various methods that we are able to identify, what would go wrong with the patient. But what we are keen to understand is what we call in a technology parlay, counterfactuals or causality, is that the decision that I take today, what is the implication of this decision 5 years down the line for a cancer patient where we are looking for survivability? Or the decisions that I take today on a patient with sepsis, what is the outcome in 5 days or 15 days or 30 days? Or the decision that I take today in terms of a patient who has undergone prostate surgery that would prevent his readmission on the 30th day. And these are some super machine learning problems that we're seeing on longitudinal data to actually work on and identify and take it in that particular perspective. The other aspect that I would talk about is, the use of conversational AI. And we are seeing that there are, flooding of chatbots that are coming in healthcare. We saw how it was both useful and at some point pricking in terms of what they were talking about in COVID. Some of them were truly information, some of them were not so informative or could be also disinformation at some point. How do we build in ethical principles in developing AI or conversational AI into the system? This is something which is very, very important. See, there are lots of laws around what we see in terms of data privacy, data security, and data confidentiality, and I think we are in a right direction world over into that. But I think simultaneously, there has to be a way and means to understand that, the way we are going to now use AI or conversational AI in healthcare needs to be, I'm not using the word regulated because a lot of people will talk about, that would inhibit innovation. But we need to talk about how this would be self-regulated. And herein we want to give you a concept of ease, which is a fallout of my work with World Economic Forum for the past 2 years on working with conversational AI. And I call it ease. E stands for ethics, A stands for adoption, S for suitability, and E for explainability. And this is not for the first time in one of these digital transformation shows of which Kavita had invited me in CII, that I'm talking about ease. This is possibly the second time of the 3 times that I've been here. Ease is very, I mean, we found it very useful to understand what you need to incorporate, whether it is a high volume or high velocity or high scalable or high variable data. You need to understand the principles of seeing ease in the perspective of safety and non-maleficence, inclusivity, fairness, integrity. We know that the garbage in is garbage out. So if you are using bad data, you will get bad models, and that they will not work for you over a period of time. Efficacy and, of course, accuracy. Whereas in adoption, we are looking at it that whether they go and integrate into your workflow or not. And this is something that you need to do it at a very first level, and we have 9 levels, or we call it 9 yards, as we do it in that way at Apollo hospitals. The next one is suitability, which is actually looking at it whether this is an important question to answer in terms of either epidemiology or whether in an individual health. And then finally, in using of the AI is about the explainability. If I, as somebody who builds the model, if my model does not talk to my physician would not be able to talk about the inference of the model to my patients. And there would be what we call as a trust deficit. So that the flow of the trust happens in an appropriate way in the system, we need to actually look at it. I'll touch the last point and I'll stop there, is once you've got the data, once you have had the data lake or kind of thing, and Dr. Anand was talking about it before me, about the cloud computing. And I think we have a tremendous amount of advantage using different cloud providers, and I don't want to be very specific, though I have an inclination to one of them, to use and piggyback them to take our APIs, and I'm talking about certain APIs that we develop at Apollo hospitals. We have about close to 1 dozen of these APIs. And what we have done is we know that we are not going to get data from any country to come into India, and that is lawfully not possible. So we are able to now host our APIs into the private cloud or tenant of that organization, whether that organization is in Netherlands or in other parts of Europe, or whether they are in US or whether they are in Singapore or Middle East or anywhere else. Currently, we have our APIs going on in 8 different countries. And what they can do is call these APIs without even having to share their data. They would be able to use it for validation, calibration, and co-creation. That power of cloud technology is something which would be very, very useful for healthcare in coming days. And on the top of it, you have computing things, computing methods like differential privacy. You have confidential computing, and all of that are now coming from different computing organizations to actually help you out in doing that, or doing what we call as federated or distributed learning. So that's the way to go forward. I'll stop there.
Thank you so much, Dr. Sujay. This has been wonderful. I picked up 2 points from what you were saying, and I'll sort of go another round with everyone. So starting from you this time. So you talked about conversational AI, and you talked about APIs being available to everybody. So I'll sort of put a combined question on that. So one is on the conversational AI. I think it is very good for things that are not clinical orders. So if it is clinical notes, if you have to make any of the hospital administrative orders, maybe conversational AI is fine. But when it comes to clinical orders, there is a risk that we have to always keep in mind. For example, carbamazine and carbamazepine are 2 drugs which are sounding very similar, but they are very, very different from each other. Now, if the conversational AI understands one over the other or one instead of the other, we will have a medical emergency at hand. So, that is something that, I would want you to react on. And the second thing is, I think the time has come about, putting an open source platform where everybody who's doing innovation on APIs should be able to contribute to the open source platform, and everybody can use it together. So all of us who are sort of trying to do innovation, we should be able to sort of dip into those libraries, which could be on a GitHub or it could be on any of the open platforms where everybody can use these APIs. So yeah, please, your last closing comments on these 2 points.
Right. This is a fascinating question, and I missed out when I was actually talking about this. Understand this from a perspective that we know, Kokila Ben or Apollo hospitals, we are all JCI accredited hospital. We know about international patient safety goals. This is entrenched into the systems. IPSG2 talks about effective communication. But are we now thinking in engineering and clinical parlay about the handoffs that will happen between machines to humans, or machines to physicians, or machines to clinicians, and clinicians to machines? How do you identify seamless movement of communication that goes from machines to humans and humans to machines? This is another active area of research. There is a seminal paper on this that came out from MIT CSAIL about almost 1.5 years back, where they tried to solve this problem. How are we going to ensure that there is a very smooth transition between this when people are using technology? And I think this will require a lot of research to go in. But for carbamazine and carbamazepine, I think, I would be more comfortable if there is a human in the loop whenever there is an order to check or verify whenever this kind of things happen in that way. I didn't get the second question, so sorry. But
yeah, so I can repeat that. So the second question is about an open source library.
Yes. Sorry, got it.
APIs, if you will.
Yeah. Second, and I would ask you to refer to the government's NHS Tech, the one that they came out with. It's a beautifully written paper, right? And I normally do not commend a paper, but this is a beautifully written paper which has come out from National Health Authority about the entire view of using open source data, using AI on top of it, and they have done a brilliant job into it. So anybody who is listening to this conversation, I would refer you to read that document where it has been clearly laid out. However, from an execution level, there are some stepping stones that I've gone through from NDHM and other activities on this. And very soon we will possibly see, when I mean soon, maybe in another 2 years down the line, we should have an open source developed where we can exchange the data and people can use it for innovation.
Sure. Thank you so much about that. So I would extend what you said in terms of open source. So, probably we are reaching a point where there'll be an open source library of minimum viable product definitions. So, the APIs being available, the definitions being available, and, people can use it as Lego blocks to build their applications, just the way Dr. Anand Padmanabhan said about, low code, no code. So, if Netflix can do it, if Ola can do it, if Zomato can do it, why can't healthcare do it? That's my point. So I think some of the let's give other speakers also a chance for the closing comments. So coming to Dr. Bernali, you talked a lot about the evidence-based medicine and clinical decision support, clinical protocols. So the question is that, India still hasn't matured as far as clinical protocols are concerned. We still look towards outside. We still look towards the, West and mature countries to borrow clinical protocols, apply it to the Indian population. And we all know that, in India, our human bodies are slightly different, because of the lifestyle we lead, because of the food we eat and everything else. So there is a need for a clinical research paradigm to start in India, build our own clinical protocols, and then do some sort of intervention where we build AI models on top of it for helping the clinicians use it at the point of care. What do you have to say about that? Because we still continue to look towards the West for all our clinical protocols.
True. So this like ethnicity driven, because Indian population, if we see even within India, we see North, East, West, and this ethnicity driven, like suppose small example, reference interval. So that we take from West for multiple parameters, like, to see normal range or abnormal range, and then clinically evidence-based healthcare. So that's actually sometimes is totally different for Indian population. So because of that, those clinical research or government funded clinical research or ICMR driven or other driven DBT and DST should take the appropriate approach, like where we can have ethnicity driven research to implement in the population, and then the population AI can help. AI can be customized according to this ethnic population, and because of that we see a lot of variation. Like for example, AKI, we try to like implement from EL, we try to implement from NHS, but when we have seen that Indian population and even the clinicians, we have gone to even same hospital, when we have gone to nephrologists and we have gone to oncologists, they have different opinion about that interval. Like, you should not use 0.3 milligram per deciliter. For oncologists, they were saying it's not related, but for nephrologists it's very much important. And EL, when we are our collaborator, we have discussed, they have lowered it down 0.2, 0.1. So the difference in the approach, like either in we take UK approach or KDIGO, like for this example, or from US example, but India is totally different. The ethnic population is different. So we need to be like this conversational AI, and we need to be like, this more customized for our population. And I think with the help of the AI and with the help of, I have heard it's overwhelming for me, like how many applications and what sort of implementation and knowledge. So because of that, we need that India based and ethnicity driven AI implementation.
Sure. What I think is it is actually the challenge is data, because right now the data is sitting either in paper. If it is in electronic, it is not in standard form. If it is in standard form, it is sitting in silos. So we are not able to bring all of the data together to do analysis. If we are able to do analysis, then we'll be able to build our own clinical protocols in India. And
Yes.
also the lack of the health
Uncertainty and
insurance.
it out, we
Correct.
don't
Correct.
understand, when we talk about the clinicians understanding or anybody understanding the data clearly, so I think we don't understand also. So we need as a whole, we can't work in silos. We should be there would be combined approach.
Sure. One of the best clinical protocols actually come out from health insurance companies, because it is in the interest of health insurance to keep the patient healthy. And I think that is where, as a country, we have lagged, because, health insurance sector was small. Now that, that is coming to maturity, maybe we'll see more focus coming in clinical protocols. Thank you so much, Dr. Banali. Coming to Dr. Anand, sir, we are sort of at the end of the time almost for whatever was allocated. But the question I would like to ask you is, what about the data privacy and data security? Because when we go into so much of, Internet of Medical Things, now that is where it becomes extremely vulnerable, so to say, because the devices have not been built for this kind of integration. They have not been built for a integrated world, and that is the point where the data breaches can happen, and they have happened in other parts of the world. May not have happened so much in India, but there are reports where a lot of those breaches happen. So would you have any comments about data privacy and data security as far as artificial intelligence and IoT is concerned?
Yeah, I think data security is really an issue. No doubt when you have thousands and thousands of devices in a hospital, can you believe my estimate is that in a 300-bedded hospital, if I implement an IoT solution both for clinical and non-clinical applications, I will have about 800 IoT devices. I have just calculated. Suppose if I have about, say, 100 cardiac monitors, and if I have about 300 infusion pumps and syringe pumps, maybe if I have about 25 ventilators, like that, if I keep on extrapolating. And same thing for non-clinical applications like water management, electricity management, temperature, then we are talking about almost about 800 IoT devices, but it does not make a distinction between clinical data and non-clinical data. There it's about privacy and data security, right? So I think it is here you need to be very careful about the value chain of that, the entire process. You're talking about IoT devices per se. Maybe these IoT devices have sensors, okay? There's some sensors, if you go to very established vendors, they give you some validation certificates. They, at the time of manufacture, if you take, I should not mention the name, if you look at Honeywell, Honeywell gives you a certificate for that sensor device. Then maybe if you go to AWS IoT or if you go to Azure, they give you some certifications on data security and privacy. Then from the user level, I think it's extremely important. Most of the breaches happen at the user level because, we don't keep our, encryptions all right. We don't keep our passwords all right. We don't, renew our passwords all right. We don't take away the passwords when the employee leave the hospital. And I think there are so many security policies which we need to follow in the healthcare institutions. In spite of all that, huge breaches happen. In the financial sector, it happens in the medical sector. But the point we need to know is, just because, if you go in a car or a scooter, the accident will happen. You cannot say, I will stop going in a car, okay? But what you need to do is wear a helmet, wear a seat belt, and go at an appropriate speed. If you are going in a highway, you can go at 100 kilometers. If you are inside the city, you go at about 40 or 50. And so I think you protect yourself. So data privacy and security is an issue. But, a lot of studies are going on, a lot of things are happening in this area. And I think it is a work in progress. Okay, but I think that does not mean that you should give AI. But I think I should mention about the application of AI because so much you and Dr. from Apollo spoke so much about it. See, in a hospital, a tier 2 hospital, can you believe in a tier 2 hospital during the COVID times where I was working, we used to get about 400 to 500 chest x-rays. Believe me, 400 to 500 chest x-rays. My radiologist was very clear that he will use an AI application for the COVID parameters, and he was able to diagnose at least about 20 or 30 cases in an hour. Can you believe that it happened? And I thought it is happening only here. Believe me, I heard a webinar like this when the Coimbatore Municipal Corporation, an IAS officer, spoke about how they used AI in that Bombay city of Bombay. So having said that, I think AI will have a lot of applications in the course of time. Maybe we are talking about the tip of the iceberg, but we have to go a long way as far as AI is concerned. But the only point is, maybe in course of time, I don't know, I was told by one of the clinicians, maybe the insurance companies in another 5 or 6 years time will believe so much in AI. Believe me, they will believe so much in an AI clinician. They will say, you need to have a second opinion from the AI doctor before you get this insurance money cleared. I think that is the level of trust they have in AI. And people like us are looking for a day of solidarity. I must close my comments by saying a day of singularity. Okay, it's called the day of singularity when the intelligence AI supersedes the human intelligence. And at that day, I think who will be more powerful, God only knows. So that is where I think India, China, and America are spending so much on AI, and they want leadership roles. But I wish that India takes a bigger role in this, particularly in healthcare. Thank you.
Sure, sir. So thank you so much about this. And then on singularity, definitely, I hope it doesn't happen sooner.
It will happen.
I hope it will happen, but I hope it doesn't happen sooner because we need
No,
time.
but I think a point here, Pankaj, and I think that is where if you read some of the webinars or see some of the webinars given by Elon Musk and maybe Google, Sundaram and all that, they are talking about regulations, AI regulations. Like you have regulations for atomic, in atomic agencies, you have regulations for the various countries. They also want regulations in the field of artificial intelligence. I think that is the only way to protect us, but you cannot, if there will be, definitely there will be some rogue states which will have AI capabilities that can be really powerful and disastrous.
Yeah, absolutely right. And that's exactly what I was coming to, that, the regulation is something we have just taken, the first baby steps as far as digital health regulations are concerned. We've put a very ambitious target in front of us, the National Digital Health Blueprint, implementing it. Yeah, I think it is going to unleash an era of digital health for all of us. But we need more time to deal with singularity, artificial intelligence, and IoT, which is still sort of untouched as far as the regulation is concerned. So, but we are fast approaching that. Because of the pandemic. A lot of things got accelerated, and we are at that point where we are going to see an era where the healthcare will be built around the digital rather than digital being an afterthought. So that is something that is coming very soon. So thank you so much, everybody, for this wonderful discussion. And over to Sangeeta. Sangeeta, if you would want to sort of, help us close the session, and if you have anything else for us.
Uh, Thank you, sir. First of all, thanks for moderating this session. My sincere thanks to all the speakers for your time and valuable insight. With this, we come to the end of the session. Thank you all. So the next session, we have a next session on emerging opportunities for Indian enterprises in the world of order, which would be just begun. Thank you all.
Thank you.